Okay, thank you, Lowell. And I think what you all should take away from everything we're talking about, laser, RF, MOCA, or anything else, if a great saphenous vein is closed, patients do well. So that's, however you close it, all their quality of life improves. So just keep that in mind. It's just, you've got to decide what's the right way to do it for that particular patient's clinical situation. And that's why we're talking about all these various technologies. So these are my disclosures. These are the categories that we have been talking about: the thermal tumescent, the non-thermal non-tumescent. There's other categories here, what I call the thermal non-tumescent, which is the holmium laser, lasers that use very low energy, so you can perhaps do this without tumescence. And then there's the non-thermal tumescent ones, which are actually a modern day inversion stripping with tumescence. And I don't know if any of you have done that, but if you do a stripping still, you should really put tumescence around before you strip. You'll find that there's significantly less discomfort. Anyhow, what we're talking about is this. How many are familiar with this device? Not used it, but familiar with it. Okay, so not all that many. So let me bring you up to date. So what this device is there's a wire that rotates at the end of this catheter. And while that wire is rotating, you're injecting a sclerosant, a liquid sclerosant, and this is the handle that makes the wire go round and round. There's a motor. It fits through a micropuncture sheath, so a 4 French sheath, you get in, and that's it, you're done. You don't have to exchange it for anything larger. This is the end of it. The catheter looks like this when you're putting it up before you begin to extrude the wire, actually unsheath the wire. Here's a wire that's unsheathed, and what happens is, as this wire is going round and round, 3,500 revolutions per minute, the sclerosant comes out here, gets taken up by the wire, and basically released directly into the vein wall, so to speak, at the tip of the wire, like a sprinkler. It comes in various lengths, depending on how long you want to have to treat for the patient. And this is just a schematic of what's going on. So the wire goes round and round, causes vein spasm. You then inject your sclerosant as you're pulling back, and you would attain vein closure. Okay, here's a couple of pearls. You should start about 1 to 2 centimeters from the junction. I usually start a centimeter. For the small saphenous, and this is for any of these technologies, you start at what I've called the fascial curve, just as the small saphenous dips down the fascia towards the popliteal. Prime the catheter with sclerosant. You begin rotation first to begin spasm and also to begin a little vortex so you don't get much forward flow of sclerosant into the deep system. This is what it looks like. It's very easily seen. This is perhaps the most important slide if you're going to do this, is that the pullback rate is much more important than the volume given. The pullback is similar to a laser, 1.5 millimeters per second, or every 6 seconds a centimeter. In the study, we use 1.5 sotradecol. You can use 2% polydocanol as well. Volume is based on the length, and there's a table that's created for what the volume is, but these are kind of the average things. The volume is forgiven. You can give a little too much, a little too little. But if you pull back too fast, you will not get occlusion. So if we take anything away from this, you need to pull back correctly. You can err on your volume. Other pearl is you can treat the first 5 to 10 centimeters, see if you have spasm. If you do, great, keep going. If you don't have spasm, you can go back up and just retreat mechanically to get some spasm. It is not an injection. It is a drip, drip, drip at the end of the wire. You just want to get the sclerosant to the end of the wire so the wire can take it up and then release it at its tip. And when you say, well, how much should I use? How fast should I go? In my mind, if you decide you're going to use 10 cc's for a great saphenous, I usually only put 4 cc's in the syringe, then 3 and 3, and divide the leg up into a third. It's easier to determine your amount of pullback rate if you shorten the segment that you're treating. Some contraindications. Post-thrombophlebitis, you can get the catheter up. It is a steerable wire. It is the angled wire that you would pull out if you can't get a sheath up, either using laser or even glue or even RF. So it is a steerable wire. That's not the problem with the thrombophlebitic veins. The problem is the catheter, the wire gets caught on the synechia in the veins, and you can't get as good of a treatment. So in my mind, I think you should consider using maybe a different technology. Large veins, I tell you, say once you start thinking of getting 10 to 12 millimeters, you may want to start thinking about a thermal device instead. I've done them up to 19 millimeters with the MOCA device, but in general, when you're kind of getting up there, think about something else. Some people say they can do calf perforators. I've done a few, but they're in general a little too short. Thigh perforators, yes. What are some of the advantages? Well, it's non-tumescent, so there is decreased discomfort. It tends to be a little shorter because you don't have to give the tumescence. Also, there's been no injury to nerves reported on with this device. You can treat all the veins below the knee. You can go all the way down to the ankle because you're not worried about nerve injury. And even with ulcers, you can go retrograde underneath the ulcer. It's very hard to place tumescence in the area of lipodermatosclerosis. For the thermals, you can treat with any of these non-thermals all the way down. And I'll show you some papers that have addressed that. So here's some of the global peer-reviewed studies. There's a lot of them, and they're 2-3 year follow-up. Occlusion rates are all in the 90s. You can see this for yourself, and obviously we're going to be getting more and more reports as people follow them longer. But clearly, the occlusion rate is good, and as I said to you, you occlude a vein, patients are going to get better from a quality of life viewpoint. There's some other peer-reviewed studies that I want to show you. Again, you can see closure. It's very good for the small saphenous vein, 94% closure, and again, no nerve injury. You don't have to worry about the sural or the tibial nerve. The third study down is a study comparing RF or MOCA, and MOCA did achieve 74% reduction in postoperative pain compared to RFA, and there was lower postoperative pain with significantly earlier return to work as well. Again, for ulcers, there's good evidence that after you do whatever you normally do for ulcers, you have residual below the knee incompetence, that the mean time to heal is shortened by being able to ablate all the way down to the ankle, and this is studied by Sullivan. There are some clinical trials going on, and some have been completed. I want to bring you just to as we get to the end here, a trial done by Alan Davies in the UK, his group. This was just reported 2 months ago in Phlebology. They are comparing MOCA with RFA for intraoperative pain. It was a randomized controlled trial. You can see that the patients were divided well, and there was a visual analog scale, and their goal was to look at both quality of life, closure rates, but more importantly, intraoperative pain. And intraoperative pain scores for the MOCA was 19, RFA was 34, and these were statistically significant, as was, this is the maximum intraop, and this is the average intraop. So in general, in their group at least, in their cohort of patients, there was less pain during the procedure for the MOCA. 1 month follow-up, they got 66% of the people back, and as you expect, and I'm telling you, you hear this theme throughout this entire meeting, the vein is closed, people get better in terms of quality of life issues, and the VCSS and VDS improved clinically, and the quality of life scores all improved. So that, again, is the common theme. Coding reimbursement, I told you that they do have a code that's been given, and I gave it in my last talk. These are the codes that hopefully we'll be using beginning of 2017. My suspicion is the work is similar for all these technologies, and I think the reimbursement should be around the same, because I think that's, however we're ablating the vein, we're doing it, we're making access, we're thinking how to do it, we're ablating it, we're following them, blah, 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 blah. So I think we're going to get the same kind of reimbursement. And that's, I think it should be live in about 10 months. So in general, more than 60,000 cases have been done, actually probably almost up to 70,000 now. Good occlusion rate, compares well to the thermal tumescence, minimal DVT, no nerve injury, no skin burns, and we'll see what happens beginning of 2017. Thank you. 7 seconds.